So while we are waiting for our other speakers on the other session,
Yeah.
may we invite
We extremely apologize for the inconvenience.
may we
Sorry.
invite Miss RENU WADHWA, who is delivering the keynote, and she's going to talk about managing finances in a community ophthalmology institute. And I think that's so important because firstly, ophthalmology itself is a field in which our returns on investment is something that we measure not just in terms of the finances but also in terms of the outcome we give the society. And then when you do that in a community setup and then manage that well, I'm sure that's a big challenge, and we're happy that Ms. Wadhwa is going to talk about it.
I'll be running you through a few simple strategies on how to manage finances in a community eye hospital setup. These are basically a lot of common sense pointers, but we tend to neglect them in our day-to-day working. I'll start with the golden rule of cost management because a lot of community eye hospitals face challenges due to rising costs of increasing salary demands, changing patient expectations, frequent change in technology. We'll start with the golden rule: every rupee saved is every rupee earned. However, we need to be cautious about not being too miserly and not cross the threshold by cutting costs so much that it affects patient satisfaction and patient quality. I'll be using the nomenclature in cost management of fixed costs that include rents, salaries, insurance, depreciation, and variable costs directly related to the volume of patients, which include material costs, consumable costs, etc. Another ground rule to remember is fixed costs decrease per unit of service with an increase in volumes. For cost reduction to be effective in any organization, we need to have the leader give importance to it. It should be an important priority in the leader's agenda. The leader needs to be alert and prompt to the changing environment to understand what is the impact of change that's going to bring in the organization. And of course, prompt decision making avoids the opportunity cost of a delayed decision making. We all know emergency requirements and random decisions always are detrimental to cost reduction. Annual goals and activities calendar need to be well in place, because else random decision making, or it's like a post-mortem and troubleshooting kind of a situation that we create if we don't have our goals and activities for the year planned well in advance. And handling post-mortems and troubleshooting are always more expensive for the organization. Instituting proper controls of expenditure would mean internal audits, a maker and a checker system, having the system of purchase requisitions, and a periodic review of the expenses. Instituting a positive work culture is trying to build a team which is focused on serving the patient. Imbibing this one important aspect in every staff member of serving, and a gentleman's attitude as to what did I do for the organization today? Did I give more than what I took from it? Positive work culture would also include empowerment, reducing bureaucracy, and promoting team playership. Instituting a culture of cost reduction. So many times, we are not aware of the realities of expenses. Like just last week, I asked a manager, what do you think is the electricity bill? And she simply said 25,000 rupees per month. So 25,000 rupees per month for a 40,000 square foot of space was a gross mismatch. So you need to make your staff alert and aware of the realities of the expenses. In addition, you can make them very motivated towards cost reduction by telling them their decision to save costs means they have the power to make a difference. Because of their savings, we could have better increments, invest in better technology, and even serve the patients better. Initially, purchases in any community eye hospital will need to be micromanaged by senior management for the first 2-3 years, and then of course it could be delegated to a competent staff. Comparative analysis always gives rise to better priced substitutes, especially when we network with other players in the industry. We need to manage our inventory efficiently, and of course, when we are looking for buying equipment, always look for good service support and low maintenance costs. HR costs play a very significant role, a very big expense in the P&L of any organization. So we really need to start right. Like in the earlier session, we had these tests for the patients. There are a lot of psychometric tests that we do for employees while hiring them. So we start right by hiring a good culture fitting into the culture of your organization, as well as, of course, competence. Functional training at the start equips them to perform efficiently earlier on in the date of joining. Aligning staff goals to management and organizational goals is really important, because then there's no scattered effect. Everyone is moving in a similar direction, and it helps in a better probability of achieving those goals. Charting out daily, monthly, annual task trackers and a clear demarcation of roles and functions avoids overlap and saves manpower costs. Another way of saving HR costs is a daily reporting of activities by the staff. So at the end of the day, they submit a daily report. That automatically makes them more conscious of what they are doing during the day, and of course, subsequently, they become more productive. We need to minimize attrition, because there's a cost of hiring and training, and of course, there's a loss of quality when one person leaves and another joins, until the second person who joins comes up the learning curve. Empowering your staff, time and motion study needs to be done periodically, where we measure the time taken for every function by every staff member. So it gives you an important idea, like if you need 7 security guards and you have 8, you're overstaffed, or you need, if you have only 5, you know you need to hire more. Similarly for all categories of staff, including doctors. Harnessing volunteer support. At what cost or efficiency is my outcome being achieved? I'll give you a simple example. When we just started the hospital, we have 4 hospitals in different specialities. So I would send the housekeeping staff to buy me a cup of tea, who would go to the canteen, which is just 2 buildings away. So I realized in a few days, I'm spending 30 minutes of manpower time, plus an opportunity cost that she could have done any other job, plus the cost of the tea. So that's a really expensive cup of tea. Analyzing your OR and OP productivity on a daily basis and tracking errors that could happen in your operation theaters and OPD, linking those errors to what corrective action that you could take. Surprisingly, we found corrective action that can be taken even on the policy level, on the process level. Maybe it's an understaffing issue, maybe it's an overstaffing issue. We need to have in place a readily available pool of tasks that could be assigned to staff when there is a sudden drop in volumes. Fixed and variable components of salary always keep the staff on their toes. When I say variable component, I don't only mean monetary incentive. I mean rating every staff member, right from doctors to the housekeeping staff, on performance, on behavior, on attitude and competence month on month as a salary component. Appropriate use of human resources, offloading to counselors, technicians, optometrists, what doctors don't need to do necessarily. Offloading clerical work. Sometimes a lot of managers are busy with very routine clerical work, which could be offloaded to junior admin assistants. Having clearly documented SOPs, standardization of not only clinical protocols but administrative processes as well. Overhauling from time to time, like a process re-engineering of all your functions to bring in about an efficiency, effectivity, and also you eliminate any redundant jobs that may be there. Aligning your workflows to cost reduction. A very simple example for this would mean, like if you have 20 camps in a month and you do the BP and BSL on the campsite, you do the BP first because you save that many sugar strips. These small costs over time do form a significant reduction in costs overall. Investment in a robust IT, like in a community hospital, we may have 50, 60 admissions on a day. The same demographic patient data is used at the campsite, it's used on admission, it's used in the OR, it's used on post-op and follow-up. So a robust IT will integrate the systems, and the same database will be accessed at every workstation. In addition, of course, the robust IT automates a lot of jobs and brings in about a certain automated efficiency. System of preventive maintenance, of course, will prevent a lot of huge costs of breakdowns, of repairs and sudden breakdowns. Policies do impact your costs in a big way. What is your objective? Is it a profit objective? Is it a not-for-profit objective? Do you want your community volumes to be driven by SICS or FACO? Do you want your consultants to do the community patients or fellows and residents? Because that's a significant cost reduction. What is the total capacity you have and how you can scale up volumes? Percentage of non-paying to paying, that's another policy decision. Full-time visiting versus visiting faculty. What are the non-core services which you'd like to subcontract, like for example, housekeeping, canteen, etc. I'll share 2 deeper insights on the revenue front. If we openly proclaim that we are a community eye hospital or a charitable hospital, it kind of dents the positioning of our hospital, it kind of dents the branding of our hospital, and that affects the footfalls of the paying patients. Another problem that occurs is patients who have the affording capacity but don't have the intention to pay will abuse or misuse your charity service, which is meant for the charity patients. We need to account and understand a clear picture of the funding inflows and outflows of the paying section and the non-paying section separately. Identifying the drainers of your revenue. It could be an ROP patient, it could be a corneal transplant, especially when we have low volume of corneal transplants. How are we understanding who's going to pay for this cost? Basically, every function needs to be identified as a cost and profit center. Coming more to the revenue side, we need to identify our key products and services and how we are positioning them to the footfall that we have. What is our target population? We may want to do a lot of premium packages, we may want to do a lot of trifocals, but that's not the kind of patients we are getting with that paying capacity. So we need to understand how we are positioning our services, and accordingly subsequently that decides how we are investing in our infrastructure. The tariff structure, of course, will be determined by 2 main pointers. One is your costs. Are your tariffs covering your costs? And of course, you need to limit your tariff to the market prices. Building awareness always helps in increasing footfalls. Data is the new oil. Unless we don't measure, we can't analyze, and we won't be able to manage. Data helps us to measure, analyze, and manage better. For example, what is the capacity that you have? What are you utilizing, and how you want to scale up your capacity? Of course, basic other data that is analyzed is your demographic information like gender, age, sex, which location are they coming from. We also use the data to understand what should be your OPD timings in the evening. Do you roll it back by 1 hour because you're not getting patients between 7:30 to 8:30? Do you shut down your Sunday OPD or you continue to run it? One important aspect is, where am I investing my funds in and what are the returns I'm getting out of it? Will I get more returns by investing in this technology and space, or simply by parking my funds in normal instruments like debt, equity, or even an FD? This we need to do by comparing your yearly inflows to the future value of investment. There's a simple formula that does it. Future value of your investment is equal to present value into 1 plus the rate of interest to the number of years. The idea behind this is no asset must remain idle, because an idle asset always incurs opportunity cost. I'd like to wind up on some common pointers of managing finances in a community ophthalmology setup. One is cost management, optimize your cost cutting; revenue management, maximize your revenue; and of course, understand what the sources of your funds are going to be, what the cost of your funds are going to be, and where are you going to deploy them. Thank you so much.
Thank you, Ms. WADHWA. Please stay back for any questions. We usually don't, by custom, we don't ask questions to the keynote speaker, but you've given us so much information that I'm sure there are any doubts, because if there aren't, I have a few. I just want to learn. You gave us a lot of information, so I just want to understand costing. And you spoke about costing as the right costing, especially to go with the market cost. For us lay people who are not really into finance, but who want to put a price on a service or a surgery or a procedure, are there simple tools that we can use, maybe online or instead of going to experts to actually sit down and analyze what is a proper
The rule
cost?
which worked for us is this: just detailing all your expenses and first giving priority to the maximum expenses. It could be your manpower cost, it could be your electricity, it could be your stationery printing costs, etc. So you put down all your expenses, all your direct expenses and indirect expenses, you total it out, and you also need to do a market survey because your prices can't go beyond the market. And based on the policy of whether you're profit, not profit, you need to understand your tariff, how much lower you need to keep your tariff than the market, due to also attract patients due to competition. So once you work out your costing with respect to all your expenses and projecting your volumes as to how much you'll be getting in the next 1 year, 2 year, 3 years, you'll come across your break even, and then that will help you to also tweak your market prices.
So we have to do that per procedure. For example, if we have to know.
Initially, periodically, it would help.